Alright guys, I hope you've seen my first two videos in this series, because otherwise this table might confuse you even more. So if you haven't seen the first two videos, I suggest you watch them first before moving on to this one. Okay, so before I discuss potassium sparing diuretics, I just want to go over the thiazide and loop diuretics once again, because I know the previous two videos contain a lot of information, so I just want to highlight the most important information from those two videos by comparing thiazides and loop diuretics, okay? So thiazides, examples include hydrochlorothiazides and chlorothiazides. We have thiazide-like diuretics, including chlorothalidone and metallazone. I hope you remember. In loop diuretics, the most common ones, we have furosemide, torsemide, bumetanide, and ethacrynic acid. Furosemide, remember, they have venodilatory effects, so they can dilate our veins. Torsemide is the longest acting loop diuretic. Bumetanide is the most potent loop diuretic. And ethacrynic acid is the one that has ototoxic effects. You know, it could affect the ear and the auditory nerve in the ear, because the inner ear contains the sodium potassium 2-chloride importers as well. Okay, so I hope that makes sense. So mechanism of action: thiazides, they block the sodium chloride co-transporter in the distal convoluted tubule. So the most important things to remember here: they block the sodium chloride co-transporter in the distal convoluted tubule. Whereas the loop diuretics, they block the sodium potassium 2-chloride symporter in the ascending loop of Henle. Okay, so thiazides, essentially, they work on the DCT, the distal convoluted tubule, where about 5 to 10% of our sodium is reabsorbed, whereas loop diuretics, they work in the ascending loop of Henle, where about 20% of our sodium is reabsorbed. So these figures are really important. Not the figures themselves, but the idea, the fact that there's more sodium reabsorption in the ascending loop of Henle than the distal convoluted tubule. That kind of explains why thiazides are only medium sealing diuretics, whereas loop diuretics are high sealing diuretic. So if you think about it, if we block the NaCl co-transporting DCT, then we cannot absorb the 5 to 10% of the sodium. And if we block the sodium potassium 2-chloride symporter in the ascending loop of Henle, then we block essentially 20% of the potassium we can absorb. So the more sodium you don't reabsorb, the more water you lose, which is why loop diuretics are more potent. We lose more water with loop diuretics than thiazide diuretics. Okay, so treatment: thiazides are first-line antihypertensives. They are used to treat mild to moderate heart failure. They're used to treat hypercalciuria, so that's high calcium concentration in the urine. They are used to for treating recurrent calcium stones or preventing the occurrence of calcium-containing stones. They're used to treat osteopenia, and then they are also used in diabetes insipidus, paradoxically, to decrease the urine output. In loop diuretics, they are mainly used to treat edema because they're really powerful in, excreting that water. So edema as in like pulmonary edema, both acute and chronic, in ascites and heart failure, when the fluid backs up into the lungs or in the systemic circulation, you could use this. Used to treat hypercalcemia, so that's high calcium in the blood. They're used to treat severe hypertension and in hypertensive emergencies due to the rapid onset of action. So adverse effects, so the first four are kind of similar. So we get hypokalemia in both of them, we get hyponatremia in both of them, we get metabolic alkalosis because we lose those protons, remember, and we get hyperuricemia. So we increase the uric acid in our bloodstream because with these diuretics, they block the organic anion transporter that transports uric acid from the bloodstream to the urine, to the tubules. So yeah, these are not good for people with gout because they might exacerbate, gout. And the main difference, the main thing that I want you to get from this is, pay attention here. Thiazides, they cause hypercalcemia, whereas in loop diuretics, they cause hypocalcemia. Because this might be an MCQ or something, so this is really important to remember. Remember, thiazides, they cause hypercalcemia because they promote the reabsorption of calcium from the from the tubules into our bloodstream, whereas in loop diuretics, they promote hypocalcemia because they increase the secretion of calcium in our urine. So potassium-sparing diuretics, they work mainly at the level of the collecting duct as well as on the late distal convoluted tubule. So this is the late part of the distal convoluted tubule going to the collecting duct. So at the level of the collecting duct, we reabsorb usually 3 to 5% of our sodium, okay? So potassium-sparing diuretics are low-ceiling diuretics, which means that they are not very potent. Certainly not as potent as our thiazide diuretics, which are medium-ceiling, or our loop diuretics, which are high-ceiling diuretics. So loop is the most potent, diuretic. So with potassium-sparing diuretics, there are two main mechanisms as to how they work. So the agent could either block the sodium channels or block the aldosterone receptors, okay? So the sodium channel blocking agents include amiloride and triamterene. Amiloride is more potent and longer acting than triamterene, okay? And for the aldosterone antagonists, these are steroid derivatives, and they have a longer duration of action compared to the sodium channel blockers. So in this group, we have spironolactone and eplerenone. The mechanism of action, as I've explained just now, we have two main mechanisms. So we could either block the epithelial sodium channels, which means that our sodium is not being reabsorbed and therefore they're excreted, and they're excreted with water because wherever sodium goes, water follows, okay? And they could also block our aldosterone receptors, and those agents are just called the aldosterone antagonists, okay? So in general, what happens is that we promote diuresis, so potassium-sparing diuretics, they get rid of water, but without the loss of potassium, okay? So that means that these drugs we cannot give to patients who are on potassium supplements because we might precipitate hyperkalemia, and that could lead to a multitude of other different problems, for example, arrhythmias. Okay, so now let's talk about the mechanism of action of potassium-sparing diuretics. So here in blue, again, as from our previous videos, we have the membrane of the tubule. So here we are at the level of the collecting duct. Here in green we have our principal cell, and here in pink we have the peritubular capillary. And again, this is the apical membrane, which is the membrane that faces the tubule. Here is the basolateral membrane of the cell that faces the peritubular capillary. So in principal cells, we have this channel called the epithelial sodium channel. So this epithelial sodium channel is responsible for the reabsorption of sodium from the tubule into the cell. So when our sodium is reabsorbed into the cell, it makes the luminal charge more negative, because obviously it's a positive ion, and when it leaves the tubule, it leaves a negative charge here, and it creates a positive charge inside the cell. So this creates something called the transepithelial potential difference. So because we've created this this voltage or this potential difference, potassium and proton, or H+, is excreted into the lumen to neutralize this negativity, as shown here. So so potassium and hydrogen, they go out into the lumen to neutralize this negative charge created by the reabsorption of sodium. All right. So you might ask, where does aldosterone come into the picture? So I'll explain that right now. So aldosterone, it shows its effect from the basolateral side of the cell. So let me just find my cursor. Right, so here in the peritubular capillary, we have our aldosterone circulating. And our aldosterone, they cross the membrane of the capillary into the cell and eventually finds its way into our little receptor right here called the aldosterone receptor. I don't actually know what it's called, I just call it the aldosterone receptor. So when our aldosterone binds to the receptor, it activates something in the nucleus, which then increases the production of something called aldosterone-induced protein, so AIP for short. Okay, once again, our circulating aldosterone crosses the membrane, crosses the interstitium into the principal cell, and it finds its way to the receptor. So once it's bound to the receptor, that activates your nucleus, increases the production of aldosterone-induced protein. And this aldosterone-induced protein, what it does is it activates the epithelial sodium channels, which means that more sodium is reabsorbed and therefore more water is reabsorbed. Okay, so now let's discuss what happens when we give the patient sodium channel blockers, which is one type of the potassium sparing diuretic. So it's actually one of the mechanisms as to how the potassium sparing diuretics work. So sodium channel blockers, they're usually basic in nature. So they enter the nephron at the level of the proximal convoluted tubule via the secretion through organic base transporters, and then they go through the nephron, and then they reach the site of action, which is the late distal convoluted tubule and the collecting duct, which is where we are at right now. So when our sodium channel blockers reach this region, this is where their site of action is, in the late distal convoluted tubule and mainly the collecting duct. So what they actually do is they block the sodium epithelial channels, and therefore sodium is not reabsorbed, meaning that sodium is excreted into the filtrate. So we increase the concentration of sodium here in our filtrate inside the tubule because we've blocked this channel, and we decrease the concentration of sodium inside our principal cells, alright? But the thing is, only 3% of the sodium is usually reabsorbed at this level, at the level of the collecting duct. So that means that we only inhibit 3% of the sodium reabsorption, meaning that the sodium loss is fairly minimal, and therefore water loss is also minimal. And this kind of explains why sodium channel blockers and potassium sparing diuretics in general are considered as low ceiling diuretics. Right, so why are they called potassium sparing diuretics? So I'll explain that right now. So if sodium is not reabsorbed, so if our sodium is not reabsorbed here, then we don't create that transepithelial potential difference, remember? We don't create that negative luminal charge and that positive charge inside the cell. We don't create that because we don't reabsorb sodium. So that means that our potassium and our hydrogen ions are actually not excreted back out in the filtrate. They remain in the principal cells. So their concentrations here stay elevated. They just stay inside the principal cells and they don't get excreted out. So real quick, let's talk about the mechanism of the aldosterone antagonists. This is really simple, guys. So basically what they do is they prevent the aldosterone from binding to our receptor right here. So they just prevent this from happening. And if our aldosterone doesn't bind to the receptor, then that means no AIP, no aldosterone-induced protein is produced, and therefore no activation of this channel. So basically we just inhibit this and the same thing happens. We don't reabsorb sodium, so we don't create that transepithelial difference, and therefore we don't excrete potassium and we don't excrete hydrogen ions. So what is the net effect? So the net effect is we increase the sodium in the filtrate, so we increase sodium excretion, and with that we also increase the water excretion, because remember, wherever sodium goes, water follows, because they just love each other. And unlike our previous diuretics, the loop diuretics and the thiazide diuretics, this diuresis happens without the loss of potassium and without the loss of protons. Alright guys, so let's wrap up our discussion about potassium-sparing diuretics. As I said in the previous slide, they are low-ceiling diuretics, so they are not as potent as our thiazides and our loop diuretics. They encourage the preservation of potassium ions, again in contrast with thiazides and loop diuretics that get rid of the potassium ions. So common uses is to treat edema. They're also used in heart failure patients to reduce cardiac remodeling, which may reduce mortality and increase the survival of the patient. They're used in secondary hyperaldosteronism and resistant hypertension. So in patients with that have shown no response with a cocktail of other different antihypertensive medications, then we might use potassium-sparing diuretics to help them. They're also used in patients with polycystic ovarian syndrome because they block androgen receptors, which inhibit steroid synthesis. But I think this only happens with high doses. So amiloride specifically is used to decrease secretions in cystic fibrosis patients when administered in an aerosol form, and they are the drug of choice. Amiloride is a drug of choice for patients with lithium-induced diabetes insipidus because they prevent lithium from getting into the tubule. Adverse effects include hyperkalemia, because we preserve the potassium in our bloodstream, therefore we increase the concentration of potassium in our body, leading to hyperkalemia. We also get metabolic acidosis because we're not getting rid of that hydrogen ion, remember? So adverse effects of amiloride specifically, we decrease the calcium and magnesium excretion. And triamterene, it's usually not used due to incomplete absorption of the drug, and it has a cocktail of different side effects that we don't necessarily want, like impairment of glucose tolerance, fructose sensitivity, interstitial nephritis, and renal stone formation. Spironolactone, an adverse effect may include endocrine alterations, for example, gynecomastia in males and menstrual irregularities in females. I think eplerenone, which is the other potassium-sparing diuretic, has less affinity for gonadotropin hormones, so with that you might not get these side effects so much. So contraindications, obviously if the patient is taking potassium supplements, we don't give this because that would just encourage hyperkalemia even more. Also with patients taking ACE inhibitors and angiotensin receptor blockers, we don't give potassium-sparing diuretics because, again, if you administer potassium-sparing diuretics with ACE inhibitors or ARBs, like losartan, for example, that can cause really, really high blood potassium levels. And again, for any reason, if the patient has high potassium levels in the blood, we don't give potassium-sparing diuretics because, again, that would just lead to more hyperkalemia. And we have to be very delicate with our potassium because potassium, either hyper or hypokalemia, is bad because just think about the heart. That can lead to different arrhythmias. So we really have to be very careful with our potassium balance in the body.